All right. Well, and thanks to Dr. Buzikuk and to the organizers for inviting me to come out and take part this morning. I actually think we made a little switch, so I went after the last speaker. I was supposed to go before, but I actually think it flows better the way it's worked out, because what I'm going to talk a little bit about is sort of the real world evidence. And I think that actually flows nicely from the sort of clinical program with the randomized controlled trial data for the SLIT tablet immunotherapy. Now, I'm going to talk about immunotherapy in general, not just about SLIT tablets. So I'm going to try to go a little bit quick because I know we're a bit behind. And I think that after all the sessions that we've already had, there's a little bit of redundancy in some of the concepts. So again, I think we can go relatively quickly. I think it's been pretty clearly already illustrated that immunotherapy is the only treatment we have currently that actually targets the underlying immune response and modifies the immune response. And it's the only treatment we have that makes a difference long term, even after discontinuing the treatment. All the other treatments that we offer may work very well symptomatically while you're on treatment, but then stop working as soon as you stop or decrease treatment. And immunotherapy is the one treatment that does have that long-term disease modifying effect. So I'm going to spend a couple of minutes talking about sort of the guidelines. And I think, again, with the last session, you got to see the really solid and robust clinical trial data behind the dust mite tablet immunotherapy program. In this article, this was an expert panel report that was published a couple of years ago with international collaboration, looked at some of the issues around allergen immunotherapy. And one of the things that they highlighted is that most of the currently available immunotherapy products have not been held to that sort of clinical trial standard. Most immunotherapy, which is, again, immunotherapy has been around for over a century, much of it has been marketed and used for decades, but with really sort of observational and retrospective analysis rather than this prospective randomized placebo-controlled trial data. Really, the SLIT tablets are the only ones so far that have been held to that sort of modern regulatory standard. And most of the other products, if they were trying to be launched as new products with their current data sort of background, wouldn't really meet that current standard by the regulatory agencies. It's also important to note that we really don't have evidence of a class effect. So we can't extrapolate the data from one type of immunotherapy to another, or from one immunotherapy product to another, even if they're a similar allergen, because many different immunotherapy products have different ways of measuring the amount of allergen. There's lots of non-standardized immunotherapy. And so we are talking about apples and oranges in a lot of cases. So what do the guidelines say about allergen immunotherapy currently? Well, again, you're going to see there's a diversity here. If you look at the area, the allergic rhinitis and its impact on asthma guidelines, they talk about sort of incorporating immunotherapy at the end of the pathway, which is in patients who are not adequately controlled with environmental modifications or medical therapies. And I think it's already been illustrated nicely that this does sort of neglect a concept that we're really trying to expand in medicine, which is shared decision making, which is allowing patients to have input on what matters to them and where do they want their treatment to go. Are they looking for long-term disease modification? Are they looking for ways to reduce their need for other medications? And I think this concept of sort of reserving immunotherapy for the worst of the worst who aren't responding may be missing a very significant portion of patients that could benefit. If you look at this algorithm from the area guidelines, it illustrates that concept of trying to measure patients' symptoms in a very structured fashion using these visual acuity scores, and then treating them and then reassessing. And again, only considering immunotherapy in those patients who continue to have a lot of symptoms despite medical therapy. And again, this neglects the concepts of long-term disease modification, patient preference, intolerance of medications. But also, if you look at this, this very simplified algorithm, really only looks at the overt symptoms the patient may be experiencing in their visual acuity score, and doesn't look at the complications they may be experiencing. So many patients don't realize how much their rhinitis may be impacting their life until you sort of walk through the complications they're experiencing. This only looks at the overt symptoms. Again, if you look at the European guidelines, which were already mentioned, they talk again about patients who have a clinical history consistent with allergic rhinitis, evidence of specific sensitization to a relevant allergen. And that's a really important concept. Again, somebody who's testing positive here to a pollen that isn't in the region, it's not going to be a particularly relevant allergen for them. And again, patients who have moderate to severe symptoms despite treatment, and they're having especially complications, but also in those patients that are looking for long-term disease modification, or again, maybe looking for the benefits of the prevention of the progression to asthma, et cetera. I think those need to be considered. So this again goes to that concept of shared decision-making. Recently, the European Allergy Organization has published on the role of allergen immunotherapy, specifically in house dust mite-driven allergic asthma. And they have this algorithm, again, that tries to walk you through the process of determining whether or not a patient has dust mite allergic-driven asthma rather than just sensitization. Now, this is tricky. You're talking about a relatively ubiquitous allergen, especially in a place like here where it's warm and humid. And it can be really hard to confirm the clinical relevance. So, I still struggle personally as an allergist with the idea of, how do I know if it's just asthma with dust mite sensitization? How do I know that it's dust mite driven asthma? I mean, if you're not doing provocation testing, which most of us aren't able to do on a clinical basis, that's a tricky thing. But again, knowing that we're in a region where dust mite is a dominant allergen, and for many patients, their only significant allergen, I think then a case can be made more strongly for treating that underlying allergic trigger. Now, if you contrast this with the American guidelines, so in their most recent asthma update from their National Asthma Education and Prevention Program, they are still advocating with conditional recommendations to use subcutaneous immunotherapy for allergic asthma, but conditionally recommending against using sublingual immunotherapy, which is very peculiar because, again, the sublingual, especially tablet immunotherapy, is the only ones that have been really subjected to proper prospective trials. And you just saw the data prospectively in randomized placebo-controlled trials looking at the impact of dust mite immunotherapy tablets on allergic asthma, with very significant clinical outcomes in both symptomatic control and decrease in medication and decrease in exacerbations. The Americans can be kind of funny in these areas, and you see that there's an editorial by Harold Nelson, who's one of the sort of godfathers of immunotherapy, sort of saying this doesn't make sense. This flies in the face of the evidence that we have, and speaking out against that panel's recommendations. Contrast that with the GINA guidelines, and they incorporate dust mite specifically sublingual immunotherapy as low as step 2, but also at steps 3 and 4 of their treatment guidelines. And so, again, you're seeing this sort of spectrum of acceptance or utility of immunotherapy across the globe. So now I want to spend the next part talking about real-world evidence. And it's important to understand that when we're talking about real-world evidence, that is not just a bunch of anecdotes. It's not just case after case. This is another way of looking at data in an objective fashion that is a bit different but complementary to randomized placebo-controlled trials. So what real-world evidence again is, it's not just a collection of anecdotes. It's looking at large databases, usually through insurance companies or through national healthcare systems. So something that, for example, we would struggle with here, because a lot of patients can buy medications over the counter without a prescription, and it would be very difficult to track a lot of that. But you're able to look at these very large patient populations rather than just a few hundred patients in a randomized clinical trial. And you're able to also look at this over a significant period of time, which again is difficult in prospective randomized trials. Now, of course, you also have the flip side of that, which is that you are not randomizing these patients. Obviously, there's a lot of confounding variables that have to be taken into account. We're not certain of the diagnostic accuracy. I mean, again, as an allergist, I see patients every day who have been diagnosed and labeled with allergic rhinitis who have a non-allergic form of rhinitis. So, you know, we're trusting to some degree the accuracy. This paper that was now published about a decade ago was one of the first large real-world analyses in one of these large databases of 1.8 million patients in Germany, looking at the role of allergen immunotherapy. So now this is all types of allergen immunotherapy, subcutaneous, sublingual drops. Tablets weren't yet really available by this point in time. Maybe the grass tablet was already out by then, I guess. I don't know if it was really included in this trial. But again, they were able to look at 1.8 million patients. They were able to look at all of their prescriptions and diagnoses, and they also looked to see which of these allergic rhinitis patients had also been labeled as asthmatic and prescribed asthma medications. And what you can see with this is that if you look at the patients who were exposed to allergen immunotherapy compared to those patients who weren't, they had a significant decreased risk for being diagnosed with asthma or being treated for asthma over the course of this decade-long analysis. And in those patients who already had been diagnosed or treated for asthma, they looked retrospectively again at this cohort to see, was there any impact with immunotherapy on the progression of their asthma? And what you see here is that there was a significant protection from the progression from step 1 to step 3 asthma, or a change from step 3 to 4. So both in very mild patients not becoming worse, or in those patients who are already moderate, moving into a more severe group. What you'll notice, and you'll see this a lot with these sort of real world analyses, is that as you follow out to the sort of 10-year mark there, 9 years, the confidence intervals widen and you get a lot more overlap, and that's because the numbers really shrink down. So you're starting with, you know, thousands of patients, and then at the end you're down to very few patients. So the results become a little harder to maintain statistical significance. That's a common theme you're going to see with some of the graphs I show you. But while the numbers are still more robust, you see a pretty clear separation with the confidence intervals only overlapping at the end, even though numerically the difference appears to be maintained. So then I want to talk about a more recent study that was done, again, a similar kind of concept, a real world large patient database study that was looking at the impact of allergen immunotherapy on primarily allergic rhinitis outcomes, medication use, symptoms, etc. But then as very important predetermined secondary outcomes, impacts on asthma symptoms, asthma medication use, and asthma exacerbations. And then a few sort of extra things that they peeked at, hospitalizations, healthcare resource utilization as well. And so they looked at patients who had been prescribed at least 2 different prescriptions for immunotherapy. They had a confirmed allergic rhinitis diagnosis and no prior venom immunotherapy. And then they had controls from the same patient insurance population that had not been given immunotherapy, at least within the previous year, but also had a confirmed diagnosis of allergic rhinitis. And again, just kind of comparing and contrasting what a real world evidence trial is compared to a randomized control trial, you can see that really these are patients, rather than being randomized, you're looking at a large patient population where the treatment is assigned clinically just in the normal flow of their care. And then after, you're looking back at those who had the intervention that you're wondering about compared to those who didn't. And of course, that does bring into account certain biases. And if you look at the entire patient cohort, so you've got, you know, millions of patients there, the N of 6.5 million patients not receiving immunotherapy compared to the 46,000 who did receive immunotherapy. If you look at their demographics, you can see massive differences in their ages and their comorbidities, the different medications they had received. So you're really not comparing similar populations, but there's ways to work around that. So they do what's called propensity score matching, which is a statistical tool where they can look at the larger cohort and find more appropriately matched controls for the patients that they're now looking at. And again, as long as you do that before you're analyzing for the outcomes that you're interested in, that's a valid way to try to create a more balanced population. So what they did in this large study is they propensity matched the controls to find the same number, 46,000, who were essentially the same with regards to their age, the comorbidities, the different medication burdens, which at least reflects disease severity to some degree clinically. And when you're talking about very large numbers of patients, it probably ends up being a valid comparison. And so what did they find with this large cohort of patients? So again, now you've got 46,000 matched patients who've received immunotherapy with their propensity matched controls. And what you can see is a significant decrease starting from the second year of treatment in their allergic rhinitis prescriptions. And again, as I mentioned before, what you see is a statistically significant separation right out to near the end when the numbers drop down and the confidence intervals increase, and now they overlap a bit. But numerically, you can see that that improvement is maintained. But certainly from year 2 all the way to year 7, after they're now well off immunotherapy, there's still a very significant, statistically and clinically significant difference in their allergic rhinitis prescriptions. If you look at the different drug classes, you see again the same idea, large decreases in the antihistamine and intranasal corticosteroid use over the course of follow-up. And if you look at the asthma prescription, same thing. Again, now you're getting down, the numbers really drop off as you're getting around to year 8 and 9, and so you don't see quite as significant a change there. But again, right from year 2 all the way through year 6, you see statistically significant decreases in asthma prescriptions for the immunotherapy treated group. I should go back a step and mention that in this cohort of 46,000 patients, about 80% of them were receiving subcutaneous immunotherapy, about 10% of them were receiving sublingual drops, and about 8% of them were receiving sublingual tablets, which were still relatively new around the time that this cohort was starting. Again, this is the kind of analysis that will continue to occur because these are done with large databases, and I'm going to be very interested to see as we see a greater proportion of patients with the tablets over time. If you look at the different asthma medications, you see a very significant decrease in rescue medication use, a lesser decrease in the inhaled steroid use, but pretty significant improvements in the use of combination therapies in the immunotherapy treated cohort. And if you look at the probability of stepping down genus steps in their treatment, you see again that for all of the years that are followed, the patients on immunotherapy were more likely to have a step down in their asthma treatment than the patients who were not receiving immunotherapy. If you also look at the risks of exacerbations or pneumonia, the last speaker hinted at this as well, you see an improvement in exacerbation risk as well as an improvement in pneumonia diagnosis. And again, how much of that pneumonia diagnosis is an asthma exacerbation obviously could be tricky, but a lower risk for hospitalization and shorter hospitalization. So again, clinically meaningful outcomes that you see in the immunotherapy treated group that you don't see in the patients who did not receive immunotherapy. From a safety standpoint, really few cases of reported anaphylaxis. Again, remember the cohort's 46,000 patients. There were 36 patients where anaphylaxis was coded using different codes for anaphylactic shock, looking only in the first couple of days of initiating the immunotherapy treatment. And the risk was understandably higher in those patients receiving subcutaneous immunotherapy. 30 of the 33 cases were in fact receiving subcutaneous immunotherapy, and lower risks, of course, of reported anaphylaxis in those patients receiving sublingual immunotherapy. So really to sum up, what you're seeing is with these large sort of real world cohort data, you see a clear improvement in allergic rhinitis medications starting early with immunotherapy treatment that are then preserved over the 9 years of follow-up, improvements in asthma treatment requirements, as well as clinical outcomes, including exacerbations and risk for hospitalizations. Again, now this is from the last talk, this is the sublingual immunotherapy data, again showing significant improvements with the dust mite tablets in inhaled steroid use, and also protection against exacerbations, and this was already presented. So again, now what you've seen is with the previous speaker, you get to see the robust randomized clinical trial data for a specific immunotherapy product, but then also you get to see the real world evidence looking at immunotherapy in general as a beneficial treatment for patients with both rhinitis and in asthma outcomes as well. And so with that, I will thank you for your attention, and I guess we're open for questions.